Hello everyone, I am Tabassum Ferdous from Central Queensland University Australia, and I am speaking from Rockhampton campus, Central Queensland. For today's presentation, my topic is Reciprocal Knowing for Diabetes Literacy among culturally and linguistically diverse individuals in Australia. And this presentation is co-authored with my supervisor, Associate Professor Roberta Heriveld. This is a part of a larger doctoral study in which I have been investigating what characterizes the knowledge base and self-management practices of individuals from regional, culturally and linguistically diverse communities living with diabetes. And what implication does this have for culturally appropriate diabetes education? I will first provide a necessarily brief summary of the context in which my doctoral study is located. Key issues considered in this presentation are cross-cultural diabetes education and issues for consumer health education. The presentation will then examine the concept of reciprocal knowing or both ways knowing of professional health educators and consumers in terms of improved diabetes literacy for diabetes management. Here, the concept of health literacy requires special attention in relation to the notion of diabetes literacy. From there, the implications of reciprocal knowing for cross-cultural diabetes education will be explored. The study that framing this presentation is located in Australia, and in particular it is concerned with diabetes that is affecting not only the general population. As a chronic disease, it is quite significantly impacting on the health of overseas-born population in Australia. For example, according to Australian Bureau of Statistics, back in 2006, 4% of overseas-born population were diagnosed with diabetes compared to 3% of Australian-born population. Furthermore, the Australian Institute of Health and Welfare in the year 2007 and 2008 found that death rate from diabetes is significantly higher among overseas born than for those born in Australia, and that the complications from uncontrolled diabetes could be dependent on the way diabetes education is provided to these overseas born people. Research tells us a patient who is well informed about their diabetes is capable of making the right decision and is capable of participating in an effective treatment plan. In this instance, diabetes self-management strategy can minimize the development of complications and the rate of disease progression. Now, Diabetes Australia is a quite influential organization, and they found that diabetes self-management can, and effective education relevant to it can also significantly reduce the burden of the effect of diabetes on a country's health system and its economy. Not only in Australia, it is an issue. According to the American Joint Commission on Accreditation of Healthcare Organization going back to 1993, patient education is one of the most important functions of patient care. With the passage of time, the current, newer, and complex treatments, accompanied with technologies, perhaps a challenge for some of the patients to follow on their own in their home. In this instance, it does become a superimposed and an enormous burden for patients who may be from linguistic and cultural backgrounds that are different from those of the instructing health professionals such as doctors, nurses, allied health therapists, and so on. Therefore, to date, health education for adults from culturally and linguistically diverse backgrounds has found to be focused on a one-way knowledge transfer from instructing health professionals to the patients. Furthermore, according to the National Council for Interpreting in Healthcare, published in 2009, the dominant language, for example English, and a dominant healthcare culture, whether it be Australian, British, or American, is only translated to the recipient's language. This means English is translated and then given to the recipient without considering their socio-cultural background. And it is up to the patient or the healthcare consumer to make sense of this information. This is a one-way knowledge transfer. Besides, this one-way knowledge transfer does not reflect the whole pedagogic process. For example, in a discussion paper of cross-cultural issues in patient education, Shakes and Christ suggested that for culturally and linguistically diverse adults, effective education was required in which the whole pedagogic process had to be altered to take into account cultural and language barrier, but more importantly to consider the resistance that impede the learning process. The authors also discussed the role of patient education within the context of cultural diversity and adult learning theory, and they found that this indicated strategies to develop cross-cultural educational programs. Individual differences and characteristics also should be considered. They suggested that individual reactions such as motivation to learn, language skill, intelligence, or capacity of understanding health issues, comfort in asking questions, the way they deal with authority, and whether or not the information is new to the person or something that is already known. All these factors have been found influence the outcome of educational intervention in the area of cross-cultural health education. That means we have to operate the service at individual level. We should not generalize, because the disease affects individual and disease perception, which is constructed at individual level. The literature review that I have conducted to date suggests that this is paramount issue to be considered in cross-cultural health education. In a recent publication by Schouten and Meusen, suggested there were 5 key predictors of culture-related communication problem that both patient and health professional may encounter while transferring knowledge about disease and its management. First, they identified the definite cultural difference in health and illness. Then there are differences in cultural values. Furthermore, and quite significantly for the purpose of this paper, the next issue is cultural difference in patients' preference for doctor-patient relationship. This also then leads to, on both sides, the racism and perceptual biases which need to be acknowledged and addressed. Finally, the most obvious one is linguistic barrier among and within the cultural differences, which is applicable to both sides as well. This suggests that it is necessary to consider Klienman's explanatory model, which is still relevant even though it was proposed way back in 80s. It has much to offer to understand how patients' cultural background may influence doctor-patient communication. Klienman defined explanatory model as the notion about an episode of sickness and treatment that are employed by all of those engaged in the clinical process. This is significant because he was suggesting that doctor-patient communication is central for knowledge transfer. According to Klienman, there will be discrepancies between patients and doctors' explanatory models, resulting in gaps in doctor-patient communication. These discrepancies result from patient explanatory models being heavily influenced by personality and cultural factors, while doctors' explanatory models are mostly based on a narrow biomedical perspective. Therefore, the dilemma and issues that has given rise my research study is clearly located in the nexus between explanatory model of doctor and explanatory model of patient and the implication of reciprocal knowledge for cross-cultural diabetes education as a consequence.